Hi, and welcome to this ACP training session for orthostatic vital signs. In this lesson, we'll discuss how to obtain and record the vitals and why they're important. My name is Alexis Farrington, and I will be your facilitator for this information. In this lesson, we'll cover a few objectives. It looks like a lot, but it's actually covered in a very short period of time. So we'll learn how to define the orthostatic vitals. It's important to know what they are, how they relate to our work. So we'll discuss our role, the importance of recording the documentation timely, obtaining a radial pulse, how to determine which cuff size of the blood pressure cuff is most appropriate for our patients. We will perform blood pressure cuff placement on the patient, and we will discuss how to obtain a manual blood pressure. We'll also look at skin integrity and the importance of protecting the skin from breakdown when using the cuffs, and we'll also learn how to record them appropriately. So what is orthostatic hypotension? It's also called postural hypotension, but it's defined as a unsafe drop in blood pressure that occurs when a person moves from lying, sitting, or standing position. Why is orthostatic blood pressure important? Well, there are a number of reasons. Physicians and nurse practitioners and PAs need this information to make medication adjustments, determine the application of safety features. We'll discuss that more. Monitor patients for status changes related to their disease process or whatever clinical reason that they have come to the hospital. Evaluate for fall risk and risk for injury, but most importantly, to determine the cause of the problem so that it can be reversed. What happens when a patient has orthostatic hypotension? Usually we get a variety of subjective complaints. Subjective meaning that these are coming from the patient. This is how they feel. They may report being nauseated, feeling lightheaded or dizzy, as if they will faint. We may notice weakness. That's an objective complaint or observation. Changes in their vision. And some may even be confused and not realize that there's a change. This is where your observation comes in as the ACP. If you're with the patient for any duration of time, let's say you're working the day shift and around lunchtime they look more weak, they may not answer some of your questions appropriately, this would be the time that you would make this, communicate this information to the nurse. So we talked a little bit about orthostatic hypotension. We discussed what it means and some brief causes, how these patients would look. Who are the patients? How will they look when they have orthostatic hypotension? We have the older adult, in some cases may have dementia or Alzheimer's or some other disease process that's related to their current illness. We have diabetics that may present with low blood sugar, which puts them also at a greater risk for imbalance and weakness. Any hospitalized patient could fit this criteria. We have, in many of our clinical areas, we have heart, neuro, surgery, and ortho patients that are also affected by orthostatic hypotension, and even dehydrated patients. What causes orthostatic hypotension? We discussed a little bit about what the patients look like. Now let's talk a little bit about some of the things that can cause them. Perhaps maybe our number one concern is drugs and pain medications. Other drugs like blood pressure medications, antihypertensives that we may give, pain medications such as Dilaudid, morphine, even anxiety medicines or antipsychotics that the patient may be taking. Any of these medications that may be new that the patient's taking for the first time and we're seeing these changes in them, or doses that were altered, either they're receiving more and their doses are more frequent, or their doses have been decreased. We may see changes in their ability to perform independently. Diuretics are another type of drug where we're giving Lasix and the patient is urinating much more, They're losing fluid volume as a result of this, and this puts them also at risk for having low blood pressures and weakness. Patients that are vomiting, this causes dehydration as well. We have a lot of patients that have metabolic problems, that their kidneys aren't functioning well, patients that are on dialysis, that are having large amounts of fluid that are removed from their blood and solutes that can render them helpless. And then we also have the patient that has a high fever as a result of infection that can become dehydrated, and these patients often need a lot of fluid and also monitoring. When a patient has a high level of infection, we also worry about confusion and disorientation. So these would be the patients that we would pay more attention to. So what can we do? Aside from taking the orthostatic vital signs, what else can we do to improve the patient's safety and monitor them better? Well, we have policies in place. We have fall wristbands, approved signs, safety features such as the bed rail and the bed alarms, making sure they have their call buttons. You as the ACP are usually the first to see the patient when any changes are due after bedside reporting is completed. So any of these changes that you may notice, or you meet a family member that may tell you the patient is looking different, this is not how they normally present, this is information that's vital and needs to be communicated with the nurse or a charge nurse if the nurse is not available. We want to record our vitals timely. This is critical so that the physicians can make the changes that they need that are necessary to help these folks. Toileting positioning needs need to be met. Now, this is a shared responsibility by everyone, but as the ACP, even if you're going in the room to do hourly rounding, it's important to make sure that these needs are met. Because patients that are confused, that are continent, may not be able to communicate a lot of things appropriately, but they do know when they need to go to the bathroom, and they will try to get up unattended. So we need to protect them from the risk for falls. So let's discuss some common misunderstandings about the orthostatic vital signs. Typically, we often hear the top three. The blood pressure is the most important or the only one that is needed. The time needs to be recorded at the same time, or it doesn't matter when they're taken as long as they're done. All of these are incorrect. The Institute of Medicine states that the heart rate, temperature, respirations, and SATs are also needed to be attained. Now, the physician may not exactly write the order that way and just want the blood pressure, but for the sake of your floor, leadership may want you to have all of those vitals recorded, and we'll discuss a little bit more about how to do that later. Recording them at the same time, again, we will discuss that later, but typically we would like them to be taken within 3 to 5 minutes apart, and this could be a little bit delayed when you have a patient that has severe weakness or has poor trouble standing. Make sure that you have a spotter or an extra person in there to help so that you don't injure yourself as well as the patient trying to lower them to the floor in a situation like that. The physicians and the providers, other providers, order these tests for a reason. The orthostatic vital signs are a form of diagnostic test, and it allows them to visualize a pattern. They may order them twice a day, 3 times a day, every 6 hours, however they order them. It's important that we have them recorded appropriately so that when they log onto the EMR, they can see how the patient is changing. Did they have this drop in blood pressure before they took their pain medicine, or was this after? Was this after we had done a treatment, or before any IV fluids were administered? This is very important. If you're not in an ICU area and patients are constantly monitored with arterial lines or pulmonary catheters, there are usually 2 ways that we take blood pressures. We take them automatic or the Dynamap. In some places, if they don't have a telemonitor, we'll use the Dynamap, or on our telemetry floors, we have the monitors that we connect the blood pressure cuffs to. And then we also have the manual blood pressure. Typically in a faster paced environment, we usually use the automatic. This is important because if your automatic cuff keeps giving you adverse readings or readings that are not don't seem to be accurate, it's important to know how to obtain a manual blood pressure, and we will discuss that later and even demonstrate it in practice. So both of these have some advantages. Advantages of the automap include that they're fast and easy, convenient. There's not that much for you to do. Just apply the cuff and go at it. Less supplies are needed. Usually you just need a blood pressure cuff and connect the patient to the monitor. On the other hand, the manual cuff requires a little bit more work. However, an advantage is that it's preferred by most doctors and practitioners. The results are more accurate. Whereas the disadvantages of the manual blood pressure cuff is, again, it takes time. This is not something that can just be done in a few minutes if you're doing orthostatics. It requires effort. You need to be able to read the meter so that you can get the correct results. These results are not automatic. If you're obtaining a radial pulse, then you're going to have to actually feel or palpate for your vessel. And we'll discuss that later. Cuff sizes are harder to find for a manual cuff because it comes equipped with a sphygmomanometer. Usually at our institution we only have at least 2 or 3 sizes. And you need more supplies. You'll need a stethoscope, and again we will discuss that a little bit more. Some disadvantages of the automap is, again, there is less accuracy. A cuff left on the skin causes damage, and the pump is not aware of how hard or how high to inflate the cuff when a blood pressure cuff is taken. So often we see patients that complain of pain when they're having this blood pressure taken by the automatic cuff. Be aware of that, because this may be one of the reasons that patients refuse to have their blood pressure taken, because of the discomfort that it causes. So for manual blood pressure cuff, we'll use a stethoscope, a high functioning, either a Littman or some other type of stethoscope, but preferably one that has a bell, and we'll talk a little bit about the anatomy of that in just a little bit. We'll also need a manual cuff with the correct size, and it's important to know where your manual cuffs are located on your unit. One of the things that doctors don't like to hear is excuses, and if we are a large institution, we should be able to access a manual blood pressure cuff. You'll need a quiet environment. Excuse yourself from the patient and let them know that it's important to have quiet so that you can hear their pulse when you're obtaining the blood pressure. So turn down the radio or the television, or ask the visitors to keep the conversation level low so that you'll be able to concentrate and get this information that's accurate. And then know how to manipulate your equipment. It's important to know how to use your blood pressure cuff, and it doesn't mean that you don't know. It just means that if we don't do it enough, sometimes we do lose it. Okay, so knowing our equipment. Here in the left frame, you see the stethoscope. This area where you see the cursor circling, this is your bellows of the stethoscope. This is the part of the stethoscope where you apply to the brachial artery to listen for your pulse when you're doing the blood pressure. The area just beneath that is the diaphragm, and this is usually the device where nurses or doctors are listening to the patient's heart and lungs. But for our purposes, we'll be using the bell. In the right frame here, you see the aneroid sphygmomanometer. The sphygmomanometer itself is a small gauge at the bottom of the page that looks like a dial with a series of numbers on it. These are the numbers that you will be using to obtain your blood pressure. And it's important to know how to read it, and we'll discuss that in demonstration. Here you see the bulb. This is the part of the blood pressure cuff where you'll depress it and squeeze the air through this tubing all the way up into the bladder of the blood pressure cuff, into the reservoir. And this is the area that you'll find right here, right up beneath this blue cuff. The air release valve is here. This is where you'll be controlling this device, turning it to the left to release the air, and then turning it to the right to lock it off so that you can pump the air into the reservoir for the blood pressure cuff. So how do we know what cuff size to use? Manual cuff sizes, as we discussed before, are a little harder to find. Most units only have 1 or 2 sizes. It's important to know this information so that the right cuff is being applied to get the most accurate numbers. On the other hand, our automated cuffs usually are more frequent in numbers, and they can be found in the supply rooms, or if you need more, you can contact SPD. For some of our smaller little ladies that have really tiny arms, the size of their arm is small, we can get a pediatric cuff for them. So in order to measure your limb or your patient's arm or leg, it's important to use a disposable tape measure, or you can use one of your own that was purchased at a store, and measuring it in centimeters to come up with your number. On the outside of the blood pressure cuff, there are a series of numbers, and usually it may say something like 23 to 24 centimeters to 35. If your number is 27 and it falls within that range, then that would be the blood pressure cuff that you'd use. Again, if you have an athlete that has a much bigger arm, you may need to change the sizes up a little bit, and we do have a regular size cuff that's actually extra long. Still get the same results, still get the correct results. Just be sure that you're using the correct cuff, because a cuff that is too small may give you a false elevation in your blood pressure, or a cuff that's too large may give you a false low number. We also have patients that are dialysis patients that have fistulas, and these are patients that we can't take blood pressures in their arm or in that limb. We also have patients that have mastectomies, maybe lateral or unilateral or bilateral, and may need to have the blood pressure taken in the leg. Again, for whatever limb that you're using, make sure that you measure and use the appropriate size cuff. This is good for the patient for comfort and also for your accuracy of results. So let's discuss a little bit about cuff placement. Here you see the patient's arm, left arm, lying anatomically with the palm facing up. This gray area you see here is the blood pressure cuff with a small circle with a line through it. This small circle represents the marking spot where you want to place your blood pressure cuff so that it's aligned with your brachial artery. There's a little black line there just below that. It's about 2 to 3 centimeters away from the antecubital space. This is the space where you'll place the bellow stethoscope to obtain the blood pressure. Further down, you'll see the brachial artery. It's labeled here. This is not where you'll check the pulse, but this is essentially where the pulse can be felt when you're checking for how high to pump the cuff up so that you'll see the numbers. So how is this done? Orthostatic vital signs need to be taken while the patient is lying, in a sitting position, and in a standing position. It's a good practice to get into to take your pulse rate before the blood pressure. In some cases, we may have patients that are COPD, congestive heart failure. These are patients that may have difficulty lying down and unable to lie flat. We may have some patients that are significantly obese or have had surgery. Some patients with liver problems that have a lot of fluid on their abdomen. Lying flat is very uncomfortable for them, and they may not be able to tolerate it. So if you have any questions, be sure to talk to your nurse about the safest position to put your patient in, because we don't want to put anyone in distress by lying them too flat. The Institute of Medicine suggests that we don't let patients go out to smoke or have coffee within at least 10 to 15 minutes before having the orthostatics taken. 5 minutes of rest minimum before we do these. And again, after you obtain your first set, record it and then move on to the next one. Try not to rely on your memory, and then make sure that you have the times. and we'll discuss the time recording in just a little bit. Before you do the sitting position, have the patient sit up for about a minute before you do the next set. Record all of the vitals and then move on to the next step. Again, if you need assistance with your standing, it's good to have someone before you get started. So take a look at this video. On the site, you'll see a link that will take you to this video. It's made by two medical students called Orthostatic Hypotension Testing. Basically, the students in the video demonstrate obtaining orthostatic blood pressures. However, the rest of the vitals are not included, but this would be a good video for you to take a look at before you actually do your checkoff. Once we recorded the vitals in the EMR, how are they going to look? This is not actually your screen that you will see on the EMR, but it gives us an example of how these vitals need to look when they're recorded. Here in your time column, you see 0800, 806, and then 812. This is a rough estimate and a safe distance between the times that you obtain these vitals. If you look at your heart rate column, HR, your pulse rate starts off at 72 and drops to 68. This is important. Usually patients have a heart rate that goes up when they're getting up. In this case, this patient's heart rate is dropping, so it's important to communicate that information to the nurse and make sure that you're reporting these results accurately. For the respiratory rate, it goes from 20 to 24. And then in your blood pressure here, your blood pressure gets normal as the patient stands up. This means that there is a fall in the blood pressure. It's important to communicate this information to the nurse. On the EMR, you can right-click on your space and free text in the name of the nurse that you reported it to. Be sure to communicate with the nurse if you have some abnormal results. Given that the patient may have received a certain type of medication and it's expected for their vitals to be not necessarily accurate, it's important for the nurses to communicate that to you so that you are sure that you have done the right thing. A normal blood pressure is usually between 120 over 80. Anything less than that is considered lower. Anything more than that is considered higher. Again, being able to recognize the difference between a high blood pressure and a low blood pressure is important. You may not be able to do a whole lot about it, but it's good to be able to see from the most recent blood pressure that you took the differences in the two and say to the nurse, hey, this blood pressure is a lot higher or a lot lower than the last one we took. You might want to take a look at these. And again, it's important. There may be some cases where you have older individuals that have a much lower blood pressure. A patient that's receiving dialysis may leave the unit with 190 blood pressure over 100 and then come back after dialysis with a blood pressure of maybe 90 over 40. Not necessarily inaccurate, but that's a big gap. So it's important to make sure you get that information to the nurse. Okay, so here you see here, obtaining a radial pulse. Just below the thumb, on the innermost part of the forearm, at the lower portion by the wrist, you see the assessor here is looking at the blood pressure, looking at the pulse rate and feeling or palpating with your index and your middle finger. This is important so that be sure that you can feel it. Some patients may have some swelling, may not want you to touch that area because of pain or even because of an amputation. It's important to be sure that you're getting the pulse on the arm that you're going to do the blood pressure cuff on. It's important to make sure that our patient's skin is clean and dry. If you're not in an ICU area, then leaving the blood pressure cuff on is not a good practice. We live in a tropical state where the weather is much warmer. Sometimes if the sun is shining into the room, it makes the room much warmer than it would be typically. You want to be sure that these patients are comfortable and that the blood pressure cuff is removed after having the vitals taken. And this is important because if the patient begins to sweat, moisture collects beneath the cuff and the skin becomes weak and susceptible to damage. A foul odor can result and a patient can end up having breakdown and infection. So we need to make sure that we're doing our part with keeping our patient's skin clean and dry. So some take-home points for this video. Communicate. If there's something that you don't understand, please communicate with the nurse. We have the vocera, so make sure that you use that to communicate this information. Being mindful that the vocera is not a telephone, and so that everyone around you can hear what is being said on the vocera. Be certain not to give patient information over the vocera. Asking the nurse if they're in a quiet area or they're alone so that they can receive this information on which patient that you've taken the vitals on. Making sure that you're obtaining accurate results is very important. The doctors are making decisions based on these values, so it's important to be sure that you have the right information. Again, if the nurse is expecting the vital signs to be abnormal, this would be important information for you to know. Not necessarily so that you can do something about it, but definitely so that you're not alarmed when you do see these results. And try not to get into the practice of telling the patient that they have a low blood pressure or extremely high blood pressure. This may make them a little bit more nervous, and then we don't want their mood or their anxiety to increase or change the value of the blood pressure and the heart rate. Practice makes perfect. Getting manual blood pressures is a lot of work. So if you practice it, you'll get it right and you'll feel more confident each time. Again, if there's something that you don't know, communicate it so that someone can take the time to teach it to you. Your feelings and your perception is important as a team player in our practice, so it's important to share your information with us. I hope this video has been helpful to you, and I look forward to sharing some more skills and techniques with you in the future.